My name is Eirik, and I'm going to talk a bit about uncertainty. And I'm going to tell you a bit about myself, but before that I would like to find a bit out who you are. Who works with patients on a daily basis? Ah, nice. Who have worked with patients but don't anymore? No one. Everyone works with patients. Awesome. Who has been working with patients after medical school, nursing school, etc. for less than 2 years? Yeah, welcome. Less than 5 years? Yeah. And more than 10 years? Okay. So we have kind of like a tilt towards experienced people here. That's awesome. I went to medical school in Bergen in 2000, and I got my AT chanced in my hometown in 2007. So, yeah, that's quite a few years ago. Today, I'm the avdelingsoverlege, as I think you say in Swedish as well, chief consultant in the emergency department and a 12-bed observation ward at Nordland Hospital. I will show you where that is. I started out, as many of the emergency specialists in Norway did, as a general internist, and then I got the specialty in 2020 as the first person in northern Norway. Since 2010, I've thought a lot about and written quite a bit on patient-physician communication, clinical decision-making, and medical uncertainty, and that's what I'm going to talk to you about. That's my PhD from 2015. I live here. Most days it's like that, actually. We also get days like this. It's really nice. It's above the Arctic Circle. It was on a few of Jørn's maps. It's within the northern hemisphere. In my hometown, this team is playing. For those of you who might, thank you. Saw them on Wednesday, Tuesday, I don't remember. It was awesome. This is my hospital. It's not that big. In the emergency department, we have 12,000 contacts per year, 2,000 admissions to the observation ward. Did anyone of you attend this on Wednesday? No one. I did. And I chose the title of this presentation on purpose to be the same as this one. But I'm going to do something very different than this one. This one was kind of like American experts talking about cases that they had. I was considering making case-based presentation as well, but when I saw this, I changed my mind. Because there's something about uncertainty that in retrospect, it doesn't seem that uncertain. Why were you uncertain about it? It's easy peasy, Japanesey, right? That's one thing. And the other thing is that, another reason it wasn't that useful is that American physicians and nurses have other problems than us. They get sued if they don't do everything they should, etc. So they have kind of like a bit of other drivers for thinking the way they do. It's online if you want to check it out. I'm going to refer to a couple of things they said, so it was not useless, but it was very useful for me to kind of like become certain about how I was going to do this. Why is medical uncertainty so difficult? I think one of the things that is key and that we don't reflect enough upon during our basic training, if it's nursing school or medical school or whatever, it's that it's founded on natural science. And natural science don't want to hear about options and potential different things. It wants fasit, as we say in Norway, the correct answer with 2 lines underneath. Right, wrong, black, white. As medical students, we are brought up to think that all questions have correct answers. It's kind of like how we operate. And how we test our students amplifies this. We ask them questions, we give them several opportunities, and they have to tick the right one. So we spend like 6 years brainwashing students in not the best way, I would say. Because when you come out in clinical practice, context matters, right? Welcome to the real world. Most of the evidence that we have been done on large group of patients that don't have all the diseases that your patient has, that's much younger than your patient is, etc. And there's available time, resources, and abilities that can be constrained for us as carers. Uncertainty is a subjective state. Uncertainty doesn't really exist. It exists in our head, right? It's our cognitive awareness that we don't know. And how can we relate to that, deal with that, live with that, and have fun with that? What separates AT doctors from those who have worked more than 10 years? There was a great study a few years ago in a non-medical journal. It was great. This is a busy figure, but kind of like what I take from this is that when you get a patient to the emergency room with symptoms, you get several bits of information, 10, 20, 50, and inexperienced physicians, they line them up and add equal value to them. It gets very hard to separate from them. While when you get more experienced, when you get them continuously, it's like this goes there, that goes there, this goes there, that goes there, and I'll focus on the 2, 3, 5, 7 that matters. And you search for information until you get enough, and you keep an open frame, and you go back and forth and change as needed. While this way of doing things, I've been there myself, it feels overwhelming. It's like when you've narrowed down somewhere, it's very hard to change course, right? You close your frame and change becomes difficult. So what real world context is not black and white. It's more like this, right? And once again, my football team, if you don't know football at all, this is like, okay, so it's 10 yellow shirts and 1 orange, right? Everyone who knows a bit about football is that this is a football team. And those who know a bit more is that it's lined up in the formation 4-3-3, right? And those who know more than that is that, okay, so they have a deep midfielder, they have a striker, they have traditional wingers. And those who know Bodø well know how they play, how they want to keep the ball, and when they lose the ball, they try to win it back immediately, right? Just an example. I'm a bit kind of like, availability bias is high on football in my hometown right now. So one of the clever doctors in the New England session said on Wednesday was that if you want to kind of like narrow it down, what does ED work consist on? It's like when you get the case, what's going on here? And the second thing, what should I do? And that, when you're inexperienced, can be very overwhelming. When you're experienced, it can be hard, but it doesn't feel choking, right? And he didn't say next step, but I don't have to find out everything. I just need to know, okay, what's my next step? What's my next step? What's my next step? And at some point, I'm happy. So I'm going to present to you some research and thought work that me and colleagues have done. And my aim is to clarify some things, sort and separate, kind of like black socks here, white socks there, increase awareness on a few things that I think most of you know from before, but maybe don't think too much about. Maybe some of you think a lot about it, I don't know. To support you and to foster some discussion, and I'll try to spend my time so that we can have some discussion. So I need to pay homage to these two guys. This is my PhD supervisor. His name is Paul Gulbrandsen. He just retired. He worked as a general practitioner before he started the research center at Akershus University Hospital, the largest hospital in Norway. This is Paul Hahn. He's from the US. He has worked several places. He's an internist, worked in palliative care. He's the one who's written most and best about medical uncertainty thus far. So in 2017, we found each other and had lunch together and started collaborating. And the picture that I showed you of Paul is he spent a month with me in northern Norway in 2024, and we went on a road trip in Finnmark, longest north in Norway, kind of like trailing past the Swedish, Finnish, and Russian border in the north. It was magical. We agreed to collaborate to study uncertainty in medical doctors, more kind of like hands-on. What are they thinking? What are they doing? What is happening? And we wanted to use both qualitative and quantitative approaches. So the first paper we published was this: How Physicians Manage Medical Uncertainty, a qualitative study where we interviewed a lot of young and experienced American physicians. And I'm now going to show you a busy slide with the figure, and don't get overwhelmed. Just let's focus on the top and the bottom. So on the top, uncertainty management strategies, we've found 4 different teams: ignorance-focused, uncertainty-focused, response-focused, and relationship-focused. The point of this slide is that what we do when we're uncertain is we try to cure it. We try to reduce uncertainty. We try to kind of like take it away. And to some extent, that is the right approach, but we can never ever get rid of all uncertainty. So for some portion of the uncertainty that we experience, we need to have palliative strategies. We need to find ways to live with it, right? How can I live with this? What we proposed in this paper or what we found and think are sensible kind of like ways of thinking about this, is that people who have tolerance for uncertainty more than others, they have that because they have epistemic maturity, and you don't have that when you're young and inexperienced. But you can have humility, you can have too much humbleness, right? But some and a lot is often a good thing. Flexibility is something that everyone can try to be, and open. Cool. Parallel to that, I interviewed, me and Paul interviewed 10 AT-läkare from Norway. And what we found was quite interesting. I really like English. It's a very fun language, a lot of synonyms, and you can kind of like write very richly, and it's a lot of fun. But once in a while, the Scandinavian language is superior, I think. And here is one example. What we saw in our interviews was that these AT doctors, they used words like usikkerhet and utrygghet interchangeably. They didn't separate between uncertainty and the feeling of insecurity, right? They spoke about sikkerhet og trygghet, certainty and safety or security, right? And they didn't separate between them. And I find that really interesting because uncertainty is kind of like our cognitive awareness that we don't know. Utrygghet, also insecurity, is the feeling that cognitive awareness puts in us, right? And they used the word insecurity a lot when talking about things like shame, not feeling good enough, and concern about what do the others think about me? Am I good enough? Do they talk behind my back, right? How do I look? And we saw that the potential for improvement in their working environments, how they got feedback, and how they were prepared was substantial. If any of you want to, I was interviewed in a podcast about this. If any one of you want to hear it in Norwegian, just check it out. So on purpose, I put this figure here in Norwegian because I think the word trygg, utrygg, is better than secure, insecure. So here, if we kind of like picture a process, here a patient comes, right? And this is, the AT doctor is notified that you're going to get the patient this and that in 2 minutes. So here, we have kind of like strategies that keeps you on the right side of things, on the upside of things, where you might feel uncertain, but you feel safe because you have trust in the system and trust in your own competency. When I talk about this line, I say that I drop beneath this line every day when I'm at work. I feel both uncertain and insecure, right? But I know where I want to be. I want to be here. So when I get lost down here, I found my way back up here, right? But people who aren't aware of this may get stuck down here, and suddenly they avoid asking questions, they can't make decisions, and they go home feeling really bad about themselves, getting low self-esteem, and some might even think, am I fit to be a doctor? And we can't have that, right? They think, what if something goes wrong because of me? What do the others think about me? Not good. Yesterday, we got this paper accepted. And this is a really cool study. My PhD candidate, Sara, she wanted to shadow 20 AT doctors. And we selected hospitals that she was going to find these doctors in purposefully. She went to the largest emergency room in Norway at Akershus University Hospital. But she also went to Lofoten and Vesterålen. Some of you may know where that is, but it's really small hospitals on the islands outside northern Norway, where the AT doctor is alone from 8 in the evening till 8 next morning. No grown-ups. So what we found, I've tried to summarize in this figure, is that there are 4 things that matter, that separates rural and urban. And it's kind of like, the first thing is how competent does the AT doctor feel, or how competent are they? That is quite predictable, right? They are what they are. Then there is how complex is the problem of the patient. That can be quite unpredictable, right? And then there's the availability of consultative support, was the word that Paul Hahn advised us to use. This is an early version of the figure. That can be quite unpredictable, especially for our first-year doctors who are in surgical rotation. If they call the surgeon, no, he's operating. What? It's like, what do I do? So it can be unpredictable. And there's a level of responsibility. While the AT doctors in the largest emergency room in Norway, they have basically no responsibility. The same doctors in Lofoten and Vesterålen, they run the hospital at that time. But it's predictable, right? They know about it. It's kind of like they've signed up for it. So, yeah, it will be published sometime soon, I hope, in BMC Medical Education, I think. Another BMC Medical Education paper that was published right before Christmas is this one. We handed out uncertainty tolerance questionnaires to 200 first-year residents. I'm more a qualitative guy, so I'm probably not the right one to present this. My enthusiasm for questionnaires is kind of like, yeah, it follows my competency in quantitative measures. So, but basically, we handed out 5 different tools to them. And I've put physicians' reactions to uncertainty in yellow, because I will speak a bit about that. And the point here is that we see that if you want kind of like to cluster first-year residents with regards to uncertainty tolerance, PRU is probably, just doing PRU is probably going to give you some pinpoint towards who are quite uncertainty tolerant and who needs extra support, right? If you use all measures, you see that it spreads out much more. It's complex. So basically what we say in the paper is that if you're only going to use one, use the PRU. But if you decide to use all of them, you will get kind of like additional inputs that could, yeah, more details. It could help you, it could confuse you, who knows. So I just put the PRU questions here in Norwegian, but they are, as you see, they're very medical oriented, while the others are more general. Next study that is ongoing, I've tried to use this survey. We handed out the survey, and then 3 months later, I've sat down and talked with first-year residents. And at some point during that talk, we've talked about what they put in their survey. So I did that to 20 AT-läkere who started in 2024. I basically spent a lot of time to get to know them, explore their motivation, understand their choices, relationship to uncertainty, and then we discussed the survey. And then I will focus on telling you what they said when I asked them to decide on 1 to 2 things that they were going to focus on to develop more with regards to handling uncertainty in the future. Basically, they were very happy about this. Everyone consented to be followed up, etc., but then they've gone, and they're not so easy to get data from when we don't have them in our own hospital. So I asked them, what would you like to focus on to better deal with and tolerate uncertainty for the remainder of your FY1 service? Here are their answers. Have greater faith in myself, keep making my own judgments, be courageous, be clear, be more independent, dare to ask, be myself, don't be afraid to ask for help, take bigger part in discussions, trust myself more, be more prepared, make my own judgments before I consult. I shall trust my own knowledge. One does not always need to have an answer. Find a level of uncertainty that is to live with. Seek, ask, discuss. Stand in the uncertainty before I consult. Gather my thoughts before I consult. Accept uncertainty. I really like that one. Accept that I need help. The one that said accept uncertainty came from a culture where uncertainty isn't a word. They don't talk about it. Uncertainty doesn't exist. So coming to a Norwegian hospital, a Western culture, it was like, okay, so I have to accept that this is a thing. I've started grouping these, not finished, but there's something about courage here. There's something about epistemic maturity. There's something about humility. And there's something about flexibility, openness, with regards to the slide I showed you previously. Yeah. Yeah. Epistemiology is kind of like knowledge. I should have kind of like the textbook answer for that, but it's kind of like, comes from Greek and yeah. Yeah, knowledge about knowing, yeah. Yeah, yeah. Sorry, you get snowblind when you just stay into words that you think you understand. So Paul, my American colleague, have interviewed five of these online after they have now started their specialization and have 5 more on the books, and we'll see what happens. Paul encouraged us to start a medical uncertainty working group in Norway, and we've had monthly meetings for about 2 years, and we decided to write a white paper series in our own Läkartidsskriftet in Norway. So we decided to have medical students write one, which was really good, a well-hidden curriculum. We had the teachers write one. Medical students need to learn to handle medical uncertainty. We had a more general one where we actually tried to emphasize the positive things about uncertainty, how it can be a spice in our everyday life, and it's not just an evil thing. And we also had a paper where we gave some examples of how uncertainty can manifest in dialogue, what kind of words we use when we're uncertain. So I was in charge of writing the 5th white paper, and my task was to give advice to clinicians. Okay, so how would I do that? The approach we ended up on was to make a parallel to a Norwegian concept called fjellvettreglene. It will directly translate to kind of like the mountain mind rules. They were created in the 50s after, I would say, kind of like mass casualties in the Eastern Mountains. 3 of my father's best childhood friends froze to death on a mountain in Norway in 1966. The coming year, these rules were revised and amplified, and from late 60s, everyone in Norway knew about them. So it's everyone knows in Norway about this. And they are kind of like good advice before you go into extreme altitude, steepness, cold weather, etc. So we ended up writing something called fjellvettregler for medisinsk usikkerhet, and we tried to translate this into English. And they have similar rules in New Zealand, and they call them land safety codes. So, okay, let's take that. So now I'm going to go through these 9 advices that we came up with. And yeah, so the first one is accept and embrace uncertainty. Clinical uncertainty often feels unnatural, especially in the early stages of our careers, when it can be perceived as a sign of our own inadequacy. This can result in utrygghet and the fear of making mistakes, which can ultimately lead to burnout. Learning to accept, embrace, and befriend uncertainty is essential for surviving and thriving in the medical profession. Okay, break down the sources of uncertainty. What are you uncertain about? We've tried to map this out. So, epistemiology, uncertainty in the knowledge base. Am I uncertain about the diagnosis, the cause, the treatment, the prognosis? Is there uncertainty around the organization of care? Who, what, where treatment should occur? How and to what risk or benefit? How uncertain is the patient and or the family? Or how utrygg are they? And the doctor's personal uncertainty. Have I thought of everything? Insecurity. Am I going to be capable of dealing with this? Next step. Find the balance between curative and palliative approach to uncertainty. In diagnostic work, as I said, our goal is to reduce uncertainty until we can rule out dangerous or potentially life-threatening conditions. What level of uncertainty that is acceptable, not only for us as doctors, but also for the patient and families, that's important. If our sole focus is on reducing uncertainty, overdiagnosis can easily occur, and we need to choose wisely. Always consider both the likelihood and severity of potential conditions and become proficient in recognizing common and dangerous conditions. That's our advice. 4, always include the patient and, if needed, their family. The best answers to uncertainty, when I'm really uncertain, my best answer is I need to go to talk to the patient again, right? Before we do diagnostic tests, we need to ask ourselves questions. Is the test necessary? Will it affect treatment? Who are we doing this for? Am I doing it for myself? Or am I doing it to reassure an insecure patient? Is the uncertainty tolerable for both me and the patient? Are we confident enough to wait and see? Wait and see is my mostly used strategy when I discharge patient from the observation ward. When they come with chest pain, abdominal pain, and we rule out serious stuff and we're not sure what it was, let's wait and see. I discharged a chest pain patient right before I flew yesterday, and I have a deal with him. I'm going to call him next week, and that's because I'm uncertain, right? So, and he really appreciated that. So he has that kind of safety netting. The patient's perspective should be central. What do they think might be causing their symptoms? That's my favorite question when I talk to patient. And often they say, I don't know. Then I ask them, what do you worry about? And then I always get an answer. The more uncertain we as doctors are, the more important it is to understand the patient's perspective. 5, seek balance between evidence-based medicine and tailored decisions. Evidence medicine is fantastic, but it has also led to simplifications that help us a lot, but also shouldn't be something that we relate to blindly. And they can obscure the complexity by applying group-based evidence onto individual patients. 50 Shades of Grey right? A variety of solutions may be valid, and the best decisions are often made together with the patient. This requires confidence that approaches outside standard guidelines and evidence can also be wise, justified, and effective. One of the specialists in a New England podcast said exactly this. 6, be aware of the difference between intuitive and analytical decisions and which tools to use in different situations. My PhD showed that we make decisions all the time. We communicate to the patient on average 13 clinically relevant decisions in every encounter. That's what I found in 400 encounters that I had from all specialties, ER, ward, outpatient clinic, etc. Awareness that decisions are often interconnected, sequential, and involve varying degrees of uncertainty is a good start. Once the diagnosis is determined, once we kind of like land on a diagnosis, everything kind of like solves itself. We can find the guidelines, yeah, you should probably have some Eliquis or something like that, yeah. We have system 2 processes where we have time to be analytical and to discuss and think before we decide. And then when we get critically ill patients, we just have to put up our pants and just do, right? And kind of like knowing about these two different modes of decision making is useful. Kind of like when do I need to and when can I take the time to think. Even less acute situations can involve considerable uncertainty. I know I teach medical students in breaking bad news and discussing prognosis. And there are simple, structured tools that can help us even in those situations. 7, make safe choices, consult with colleagues, find the balance between humility and courage. Humility in the face of uncertainty is a safe starting point, but there will be times where we need to be courageous, right? 8, know when to turn. Venn I tide, the Norwegian mountain code says. There's no shame in reassessing. Be open and flexible to changing course. I briefly touched upon bias and heuristics, but we can get fooled by our own brain, and we should be mindful of being trapped by our own assumptions. Overconfidence should prompt us to ask more questions. Always consider probabilities and alternative diagnosis and solutions. Adjust your course when new information calls for it. And sorry to say, we all make mistakes. I've done a lot of them. What I've done, when I've done them, I've acknowledged them and I try to learn from them. Final advice, stay calm, seek support when needed, offer request and supervision, offer and request supervision and feedback from your colleagues. How much do we focus on this, how we talk about uncertainty? How accurate are our observations when we observe colleagues in our working field? And how constructive is our feedback, if we ever give any? I think we can improve a lot here. I think one of the reasons that we are not good at giving feedback to each other is that many feel uncertain about how to do this in a way that facilitates learning and is safe for both them and for the one who's getting feedback. I'm currently writing a paper about the Aloba model. I didn't invent it, but it's kind of like, it's it's 30 years old, and you can find it online anywhere. It needs to be revamped. It's my go-to tool to give feedback to colleagues in a way that makes it predictable for me and very safe and constructive for them. A useful rule of thumb when giving feedback to a colleague is give specific praise and questioning critique. If somebody does something good, don't say just, good job. Say, what you did there, that thing, awesome. Keep doing that. If somebody does something that is not very good, be curious. Ask, so when you put down that tube, what did you think? Be questioning rather than direct and confrontational. So, in conclusion, the experienced clinicians, there are quite a lot of us in this room, we need to lead by example. Openly discussing, demonstrating, and normalizing uncertainty, both personal and medical, and help foster an environment where it's safe to expose our own uncertainty. Together, we need to build a culture where embracing uncertainty becomes a part of our professional DNA, and a joint effort to develop and improve our performance collectively. This will not only benefit our patients and the welfare system, but also help prevent the feeling of insecurity and eventual burnout among us. Thank you. So, it's Friday afternoon. I've kept my bit of the promise. We have 5 minutes. Anyone want to object? Or
Thank you. Yeah, I'll strongly object to everything you said. No, not at all. But you talk a lot about junior doctors' insecurity and how to sort of manage them and the strategies about that. What I find in myself is that I'm becoming much more aware of risk and actually feeling worse for every year of experience that I gain. Is there anything that you can say about senior clinicians' way to cope with risk? We're often the sort of end stage and we actually have to make a decision. It's limited resources that we can reach out to, even though we can discuss a case with a colleague, but we're sort of the end stage in the decision making.
okay, so I struggle with the same as you, and I have kind of like, to keep a very long story very short, I have 4 words that I live by, and they are curiosity, clarity, empathy, and courage. I've written a paper about them. It hangs up on the wall there. It's also published. It's called Clinical Experiences Using Gulbrandsen's 4 Virtues. And I describe there how things that previously made me feel very bad has now been something that I've learned to cope with. And one of the things I will kind of like really put out is that being able to respond with empathy to patients and colleagues when they suffer, to say something empathetically, has kind of like been a game changer for me. I know that's not what you had in mind when you asked that question, but we can discuss it further, probably in a more efficient Swedish-Norwegian discussion. Thank you. Perfect.
So, what is your reaction to when you talk to patients about uncertainty? How do patients most often react to you speaking to them about uncertainty?
Excellent question. And that's one of the reasons why America gets a bit kind of like strange for me, is that when I try to involve most of my patients in uncertainty, try to do shared decision making with them, I get pushback. It's like, you know best, you're the doctor. Yeah, but here, we have 2 options, and I want to have you decide between one of them. And if I push insecurity, uncertainty on them when they don't want it, I'm diminishing trust between us, right? So I probe, I kind of like introduce uncertainty to them. And if I see that they embrace it and they want to discuss it, let's hear my options. I can do 1 or 2. Yeah, let me hear more about it. What are the risks and benefits? I proceed. But if I get pushback, my conclusion is that the weight of uncertainty is mine to bear. It's not mine to put on the patient. Right. So there's kind of like no one answer to it, but feel your way forward. And my experience is that if patients don't want uncertainty, I'll hold it and carry it for them.
Because that's my experience as well. When you try to follow the recommendations in a lot of guidelines, when you end up in an uncertain place, is shared decision making, and that works very bad in my practice. But it's interesting to hear that.
So I don't know how it's in Sweden, but in Norway, people are so grateful. Sorry that you had to wait 8 hours. No worries, because they know that they're getting equal, good quality healthcare. Everyone gets the same. Trust in Norwegian healthcare system is very high. I suspect it's the same in Sweden. So shared decision making is for those who want it. It's not. It shouldn't be our modus operandi in Scandinavian countries, I think.
It's not obligatory for the patients.
No. No. But if they want to, I'm happy to do it. It's fun when you have patients who know what they want to know more. And it's a lot of fun. Yeah, behind you. Just throw it.
Just to add on to that, I'm a second-year resident in Göteborg, and it's something that I've often reflected on, is that I try to communicate with my patients and sort of share the decision making, but I find sometimes that in trying to be honest with them, I'm also sort of not breaking the trust, but they can see that I'm also uncertain, and then they become uncertain, and it's something that I struggle with sometimes, because I want to have an open dialogue with them, but because of my own inexperience, it's hard for me to hold that decision making and that uncertainty for them sometimes.
In my PhD, I studied 400 doctors talking to patients, and one quick observation: the more uncertain we are, the more we talk. We should stop doing that.
Yeah, and that's
so
what I'm starting to
when
learn.
we're uncertain, I try to drive kind of like the information giving by finding out what does the patient need to know here. So, okay, so we've found this and this, but we don't know that. What do you think about that? And then I just have the dialogue go forward, kind of like by them interviewing me instead of me lecturing them. Yeah. When we lecture, we overestimate how much the patients get out of it. We've actually studied that as well, and it's around 50%.
Yeah, you can sort of see in their eyes, it just sort of goes blank, and then they get confused.
Yeah. So when you see that in a patient, just stop and ask a question, and then see what happens. I think we've spent our time. Thank you so much, everyone, for being here and for great questions.